Welcome to another lecture, and today we'll discuss something about ADHD, attention deficit hyperactivity disorder. So, ADHD and autism spectrum diseases are the commonly asked questions in exam, and I want you to remember the basics about them, which would help you write better answers in exam. So, ADHD is age inappropriate hyperactivity, impulsiveness, and inattention. Now, this is a very common thing in schools, and many people are overdiagnosed, and many children are underdiagnosed with this disease. So, hyperactivity is usually the first of the bunch. Then impulsiveness occurs, and then inattention occurs. So, this is usually the flow. This is usually the flow of clinical features. Initially, it begins with hyperactivity, and ADHD is prevalence of ADHD is around 5% in the West. So, initially they were just saying that the children who are ADHD are just more mischievous than the other children. Now, ADHD has been, diagnosed with specific criteria. So, that is very important to notice. And the prevalence of ADHD in Western countries is around 5%. And there are multifactorial causation for why ADHD occurs, genetic or environmental or CNS factors, and then there are modifiers. Now, what is the prevalence? So, male to female ratio is skewed towards male. Males are 3 times more likely to be diagnosed or to suffer from ADHD compared to females. And, multifactorial analysis gives us genetic, familial, and environmental triggers or causes of this disease. And a familial or a genetic cause might be, there is abnormality in dopamine receptors. So, dopamine receptor abnormality has been implicated in patients with ADHD, and that you have to remember. Now, what are the clinical features that are associated with children with ADHD? So, what is that? It usually begins in infancy. And in infancy, these children are difficult to hold and difficult to soothe. Difficult to hold and soothe. Now, it does not mean that each and every child that is difficult to soothe will have the history of will turn into an ADHD child, but with the benefit of the hindsight that in future, when we had retrospective studies, then we recognize that in infancy these children were difficult to hold and soothe. There may also be some amount of bias over here, so please take this with a pinch of salt. In infancy, they are difficult to hold and soothe, and they cannot sustain attention. They do not sustain attention in things they don't want to do. So, like if you, give them to play PlayStation, they will play for hours. They will not have any issue. But if you put them in the chair and tell them to study, they will not study for 2 minutes. So, in the activities that they want and they want to do and they love to do, they will sustain attention on their own. But in activities they don't want to do, they cannot sustain attention no matter what, and they will be fidgety. They will be irritable, they will be distractible. They are in school. What happens is that they require every small reason to get distracted from, the focused activities that they do in the child, and they are usually labeled as brats and mischievous children, and they cannot remain still in the class. And they are jumping around over here and there, and when the teacher asks, they cannot wait for their turn. They put up their hand up. And if the teacher does not select them, they jump around to gain the attention. So they cannot wait for their turn. So these children cannot wait for their turn. They are very, very impatient. And they have a very little focus. Now, they have little focus means that they jump from one activity to other. So what happens is that child is doing a Hindi subject homework, and then they jump to an English homework, and then they go out to play, and then after 10 minutes they are doing something else. So they cannot sustain doing one activity. They have abnormal low focus, and they jump from one activity to other, and they ignore homework, and they make careless mistakes. Now, see, when I am, putting up so many clinical features of patient with ADHD, I am the one who, suffered from 90% of this abnormality. So, See, ADHD can only be diagnosed in patients who have attention deficit, and this attention deficit, worsens their scholastic performance. So these children of ADHD have they have abnormal scholastic performance, and they are usually underachievers. So that is important. That you cannot diagnose each and every impatient child with ADHD. That is very important. Okay. Also, they have they blurt out answers before they can get their turn, and sometimes they are so impatient that it might look like an aggressive behavior. That why are they cannot wait for their turn, and if you make them wait, then they'll get aggressive. So that is very important. Now, what are the secondary causes of ADHD? Secondary causes that should be ruled out before you make the diagnosis of ADHD. See, ADHD should be made if all other secondary causes are ruled out. So, what are the secondary causes? Like drugs, which are drugs like vigabatrin and phenobarbital, or they have mild MR, or pervasive developmental disorder, or lead poisoning, or thyrotoxicosis, or child abuse. So these things have to be ruled out. And even there is some amount of irritability in iron deficiency anemia. So these are the causes that you have to rule out first, and then only once these have been ruled out, you can label a patient as ADHD. Now, in ADHD, multiple abnormalities have been laid out, and there are multiple signs that you might find in MRI, and multiple etiologies like additives or diabetes or sugar intake has been correlated with ADHD. But see, definitive evidence of causes of ADHD is multifactorial, that there is some amount of genetic factor, and then there is some amount of environmental factor, some amount of family factor, and some amount of acquired factors. And as you know, heredity or twins have 90% prevalence of ADHD. So that is a very heavy support in evidence for the genetic factors. Now, investigations are of very limited value, and these patients have to be dealt with a very, very patient hand, and you have to rule out all the above causes that I have given you. And there is no role of CT, MRI, brain X-ray, skull X-ray, this and that, or EEG. All this have no or absolutely zero role, and you have to rule out fragile X syndrome, and sometimes you have to also rule out hyperactive or actually hyperactive or over anxious patients, and over anxious parents and teachers. So they might be over diagnosing or over telling you the complaints that the child does not have, and this is very, very important. Now, this ADHD is associated with a variable degree of scholastic impairment, and that you have to, dealt very carefully. There are learning disabilities also, so that all you have to deal with very carefully. Now, management is behavioral therapy. Behavioral therapy. Here in behavioral therapy, what you have to do is you have to help them do calming exercise. You have to follow a daily. You have to tell them to follow up a daily routine. To tell them to follow up a daily routine. You have to tell them to focus on one task at a time. They should not be jumping one task at a time, and then they should be, learn to make eye contact. And you have to be warm, you have to be gentle, you have to be patient. You cannot be like them. And slowly, the child will, with close monitoring, with a regular follow-up, the child usually will improve. Now, drug treatment is very important, and the drug of choice are stimulants. Now, why are stimulants? So, in this patients of ADHD, stimulants have an inverse role, and the stimulants actually what happens is that frontal lobe dominance when is there. So, when you give stimulant, there is an increase of frontal lobe dominance, and this frontal lobe dominance will control hyperactivity. So, how does stimulant act? So, stimulant have a frontal lobe dominance, and this will help control hyperactivity in the patient. But you have to remember that you have to start low, and then you have to take them up. You have to step up, and you have to be very careful about the side effects that the stimulant drugs have some amount of sleep deprivation, insomnia, altered sleep wake cycle. The child might inversely become more active initially. Now, the drug of choice is a methylphenidate. It is a stimulant, and it is methylphenidate in simple words is a weak amphetamine. So it is very, very potent drug, and you have to be very careful. The other drug you can use is atomoxetine. Now, atomoxetine is a noradrenaline receptor uptake inhibitor. Receptor uptake inhibitor, and it is a non-stimulant. So there are two categories of drugs that you can give. One are stimulants and second are non-stimulants. So atomoxetine is a non-stimulant drug and it is a noradrenaline receptor inhibitor, and it is given 0.5 to 1 mg per kg. And this is now growing up to be the drug of choice compared to methylphenidate. Though methylphenidate is the first line, atomoxetine is now gaining popularity because of its non-stimulant. The stimulant side effects are absent in atomoxetine. So that is why usually we use this drug. The effects of drugs in ADHD take around 1 to 2 weeks to develop, and they should be triggered. So they should be clubbed along with the therapy or the counseling therapy, and that is again very important. Tricyclic antidepressants and or other antidepressants or antipsychotics should be avoided, and these drugs usually have phenomenal response in patients with ADHD, and this should be always and always clubbed with appropriate therapy and behavioral improvement in all patients. I guess that's all for today, guys, and I hope you like the video, and I'll see you in the next one.